It's a great pleasure to be coming to you from the United States today and to be asked to deliver a lecture to the Chinese people on the occasion of this Congress right around Virchow's birthday. These are my disclosures. I'd like to begin by talking about Professor Rudolf Virchow. In 1856, we see here his, it's a historical piece because this is his original lecture hall, was bombed, but they kept it the way it was. And you can see in the picture insert there, the way the lecture hall was before the war. And Professor Virchow was important because in 1850, because we honor him on World Thrombosis Day. We'll get into that in a minute. But let's just talk about this venous thromboembolism. It's the leading preventable cause of death after surgery or hospitalization. 10 million deaths worldwide, 300,000 US deaths, 544,000 European deaths. And we know that fatal pulmonary emboli cause more deaths in 1 year than breast or prostate cancer, AIDS, and motor vehicle accidents combined. Now, again, about why is Virchow so special? Well, in 1856, he put forth and proved that the three elements responsible for producing a blood clot included vessel wall injury, venous stasis, and hypercoagulability. And when all three of those were present, the incidence of thrombosis of the veins was very high. Now, we know that this is the leading cause of death, and here you can see clearly a pulmonary embolus blocking the main pulmonary arteries. And we know that using risk assessment, and I would add not only with the Caprini score, but there are other good scores, of course, and using it, but you must score the patient. And based on scoring, you can prescribe anticoagulants based on the patient's level of risk and save them. Unfortunately, PE mortality has increased over the past decade. Very disappointing. The Caprini score is a thorough history and physical, and that's why it's important. As the number of risk factors goes up, the incidence of VTE goes up. Each risk factor has a different power, and combining the powers of the risk assessment factor and the number, we come up with an equation which results in a score, which is a nonlinear increase in the incidence of venous thrombosis clinically relevant based on the numbers. So as the number goes up, VTE rate goes up. I'm indebted to all the people around the world, particularly China, who have done so much to do studies to show the value of this score. Not only the value of it, but where it needs to be improved and where it needs to be changed and lessons learned. And there are now 230 publications in PubMed as of today regarding this score. Now, in 2012, the Chest Consensus Guidelines came up with the Caprini score as one way to score surgical patients and said if the score was 5 or above, there was a 6% chance of a venous thromboembolic event without prophylaxis. Well, that was in 2012. But now we've learned a lot, and a great deal of the studies from the Chinese have explored this. The set point for highest risk patients. What am I talking about? Well, we know that Chest told us the risk of 5 and above would give a 6% incidence of VTE. Let's look at some actual studies. In general surgery, it's a little over 1% with a score of 5 to 6. In head and neck surgery, it's less than 1%. In plastic surgery, it's 1.3%. And in burn patients, and this is a Chinese study, it's very low, below around 0.5%. On the other hand, if you take a look at the set point of over 8, 9 and above, the numbers jump to 6.5% in general surgery, 11% in plastic surgery, 18% in head and neck surgery, and in burns. Very, very important for people to understand and to learn these lessons. Now, it's one thing to have a 40-element score, but it's another thing to get that done. And one of the ways that we've tried to figure that out is to invite the patients to participate in their own healthcare. And again, thanks to brilliant people from around the world, this risk assessment, patient-friendly, has been translated into a variety of languages and is used all over the world. This is what it looks like. There's two important elements. The first is obstetrical complications, and the second is family history of thrombosis. Now, as far as this family history of thrombosis goes, it's the only risk assessment out there other than the Department of Health VTE risk assessment tool in the United Kingdom. And using that tool and mandating its use over a 2-year period lowered the death rate in the United Kingdom. And part of that reason is because they tracked family history of thrombosis. Now, we know that there's a billion people that use WeChat every day. And the WeChat is a very friendly type of thing that also can be used back and forth with hospitals to provide patients with data and vice versa. And in China, this patient applet has been developed on the Chinese version of the Caprini Score, which again, by the way, was validated in a very nice study in China as well. And the self-assessment form has been shown to be beneficial for the majority of patients. And patients are urged to not only finish the form, but then to take it to their physicians, and then that can be put in the medical record and available. And I think if this is really done well, if you go to any hospital anywhere, they should be able to pull up your risk score eventually. So that's a great thing. Because why? Because that'll lower deaths. Now let's talk about these obstetrical complications. Unplanned abortions, stillbirths, premature birth with toxemia, or growth-restricted infant can be clinical signs of a very serious thrombophilia set of defects, including 1 or 3 of the following: lupus anticoagulant, anticardiolipin antibody, or beta-2 glycoprotein. And by the way, if all 3 are positive, the incidence of venous thrombosis is very high. These women may or may not carry these defects throughout the rest of their life. They have to be tested if they have this history. And that's a very important preoperative consideration. Another important consideration, as we've already talked about, is family history of thrombosis. And this is a 183,000 patient study from Scandinavia, and it shows an increased VTE incidence, not only among first degree, but second and third degree relatives. And the genetic component of family clustering of VTE is strong. And therefore, family history is potentially useful for clinical VTE or risk assessment, even in second and third degree relatives. And as we know, most patients that develop clots do not have a positive thrombophilic test to go with it. So we can't rely on those tests, but we can rely on a good history. And there's even a slightly increased incidence of venous thrombosis in partners, because people that live together often have common lifestyles. Now, when a patient comes to the hospital, you can't just do a score, whether it be Caprini score or whatever score, on admission only. As they go through their hospitalization, if it's a medical patient, they may need surgery. If it's a surgical patient, they may have a complication and need to be reoperated, an infection drained, central lines placed to control IV antibiotic administration, or unexpectedly a cancer diagnosis. The updated score will often result in a change in the thrombosis prophylaxis, including post-discharge anticoagulant prophylaxis. Very key points. There's several key points about risk assessment, and this is one of them. It's a dynamic instrument. Now, I'd like to talk a little bit about, on this occasion of Virchow's birthday, this is a perfect time to talk about this, because the effects of anesthesia replicate Virchow's triad. You have venous stasis due to calf muscle paralysis, and when the muscles are paralyzed, the veins distend. There's nothing to keep their tone, and they eventually overdistend and form cracks. So now you have venous stasis and endothelial damage. And then hypercoagulability occurs secondary to a variety of mechanisms. The surgical stress, the reason why the patient's being operated, especially if it's cancer or infection. Retained metabolites of the tissues are still metabolizing. And if those retained waste products sit in that pooled blood in the calf, then that further increases coagulation. Time of anesthesia increases and intensifies these effects, and that's why the use of pneumatic compression devices, pumps, are critical to minimize these changes. The people that want to do away with these pumps in surgical patients are mistaken. They haven't carefully looked at what happens with Virchow's triad. And of course, the pumps don't reverse all of these, but they do modify those factors. Here is a 1,000,000 power micrograph of a capillary that shows the cracks that form in the endothelium, allowing the blood to get exposed to the subendothelial collagen, and then that'll begin clotting. And here we see actually a picture of a white cell that changes into an adhesion molecule when the blood slows in that static segment you see that we talked about. And when that happens, this white cell turned into adhesion molecule will attach itself to the wall of the capillary. It will release granules, causing an inflammatory reaction. Other cells will come along and join. And as a result of that, there's damage to the capillary, which is irreversible. And here is an actual picture of that in the experimental situation. And here is an adhesion molecule that is actually penetrating the capillary wall, about to break through. Now, another phenomenon that occurs is a phenomenon with a straight leg. If you straighten a leg, you'll see here that the popliteal vein may be occluded in some patients due to the head of the gastrocnemius muscle. So that's why it's important when patients are on the operating table that they be in a slightly flexed position with a pillow under their knee. And also, if you're putting on straight leg braces and straight full extension, you have to be aware of this. It's a risk factor for thrombosis because it slows the outflow of blood of the leg. You add that to non-weight bearing, where we know there's no increase in baseline blood flow, you have a situation set up for a thrombosis. Now, another important issue is the disconnect between a good protocol and its implementation. And just like the poor man here that got separated from his motorcycle, if you don't connect and implement a good protocol, then you will not be able to reduce the death rate. And one of the reasons why that death rate hasn't been going down is because it's been unpopular to try to mandate implementation, especially here in the United States. People have very individual ideas about what they want to do. And so it's really a difficult thing, but it's a really good thing. And of course, any physician can opt out of the mandatory implementation if for any reason he or she feels it's a reason why it's not appropriate for their patient or why their patient doesn't qualify. Of course, they have the ability to opt out, but in general, they should go along with the prophylaxis. And here's a good example of that from Boston University, where they had a high incidence of venous thrombosis. Here in the green line is the national average, and down here is where they wound up after they implemented their program. They lowered the incidence of all VTE to 0.1%, including deaths at 30 days. How did they do that? Well, what they did was they had a mandatory protocol that if your risk score was from 5 to 8, you had to have 7 to 10 days of low molecular weight heparin injections. Didn't make any difference if you went home or not. It was about adequate prophylaxis for the period of time shown in previous clinical trials to be efficacious. 89% of people complied with that. What's even more important is that if you had a score of 9 and above, you got 30 days of low molecular weight heparin. Compliance was 77%. Well, how is this possible, you might say, and especially in these day and age where there's a lot of patients that can't afford this drug and so forth? Boston University, which has an obligation to take care of indigent patients in their area, made a deal with the drug companies that any patient that needed this drug would get it regardless of their ability to pay. What a poster child for the nation. Imagine if every hospital in the United States followed this protocol, how they could lower the overall incidence of venous thromboembolism and have that PE rate actually go down and not up, as I showed in the beginning. Now let's go back to some very important studies in China. This is in medical patients. And you can see as the Caprini score goes from 5 to 6 to 7 to 8 to over 9, the tremendous increase in VTE risk assessment. I think you might say this is an exponential increase in risk. Now, on the other hand, taking a look at two scoring systems, comparing the Caprini to the Padua, it's no wonder, of course, that the Caprini score has a higher pickup rate because it looks at more factors. Now, that's nothing against the Padua score because there are many scores. You can't always do the same score everywhere. It depends on your country, your resources, your culture, your medical system, the ability to collect the data. So any risk assessment has to be done. Now, we like the Caprini score, but you need to do risk assessment. Remember, there are many roads to Rome, or in this case, to Beijing. Here is the largest single study done in collecting data about the Caprini score. It's 2,795,000 patients in 4 Hanoi hospitals over a 2-year period. Again, you see the same graph. The numbers are slightly different because it's a different country. It's a different set of circumstances. But the overall effects, as the score goes up, the VTE rate goes up. Everybody in the world that's ever done this, that's done it properly, has gotten the same results. Some people that haven't gotten the same results, sometimes they may not have collected the data as well as they should. Now we go to Russia, same curves. This is a group of highly complex surgical procedures, patients who were at great risk, and they were all scanned with a duplex scan. And there was only a 1.9% incidence in patients who had a score of 5 to 8. When it went up to 11, it was a quarter of the patients, and 65% of the patients with a score of 12 to 15 had a positive duplex scan. Now that was used for further studies where Dr. Kirill Lobostov showed that the administration of pneumatic compression, in addition to low molecular weight heparin, cut the breakthrough rate, which was very high. You saw that up to 65% incidence, cut it down to a very low rate by using pneumatic compression. Pneumatic compression is very important, not only in the situation of the operating room, but in the situation of very high risk patients. It's all about risk assessment. And here we go back to China in lung surgery, dramatic results. And this is what I meant. This is one of many examples from China that shows how the set point of 9 and above was established. They call it the modified Caprini score. And the reason is because they identified early on that 5 and above wasn't the right endpoint. The highest risk group was much higher than that. And here we see a 40% incidence when the score is 9 and above. And here's a study from America where there was a very low incidence of thrombosis in medical patients. But yet when you take a look at the Caprini score, it's the same graph, isn't it? And they say the Caprini score didn't help them in this study from the University of Michigan. But as a matter of fact, it showed the same thing. There were other things with that study why it didn't help them, but that'll be covered at another time. It's very important that the Chinese have published the most important studies using the Caprini score to date. And in 2019, one of my associates summarized a lot of these studies. There are many more now, of course. Now let's talk about COVID-19, which is a virus-induced inflammation triggering cytokine storm, causing tissue factor release, thrombin generation, fibrin formation to coat the virus and prevent spread. The unfortunate side effect is thrombosis. And in addition to that, what happens is we're seeing a large number of in situ pulmonary thrombi, along with strokes and thrombosis in every organ of the body. And of course, they're all supplied by vessels, and in those vessels, the endothelium can be attacked. And you may have microthrombosis. Fibrinolysis occurs because of the thrombosis, and a DIC picture can result in certain patients. And here is the beautiful alveolar endothelial interface. That's a primary target of attack for the COVID virus, which attacks like spears or arrows into the cells here. And it's facilitated by an ACE2 receptor. And look at the broad range of reactions, both clotting and inflammatory and antigenic, that occur. And these all reactions represent a very serious constellation of events that we're now going to discuss. Oscar Ratnoff, history. Oscar Ratnoff was a famous hematologist that developed the clotting cascade with Davies. As a matter of fact, he was a little bit disappointed he didn't win the Nobel Prize for it. Probably should have. But the first factor in the clotting cascade that they invented is factor 12. And Oscar Ratnoff had a particular interest in factor 12 because he discovered a patient who had a defect, John Hageman. Unfortunately, John Hageman had very low levels of factor 12, and unfortunately, John Hageman eventually, ironically, died of a fatal pulmonary embolism after an auto accident. In any event, Oscar Ratnoff showed that 4 experiments that were done in the 1800s would explain what happens when factor 12 is activated. It activates platelets, coagulation, fibrinolysis, complement, and kallikrein systems. So you have activation of clotting with clots. You have activation of complement, inflammatory responses, and you have kallikrein system activation, which is like what you see with an antigen antibody reaction, but there's no antigen antibody here. This is through factor 12. And the overall result when factor 12 gets activated is thrombosis, fibrinolysis, increased vascular permeability, vasodilatation, bradycardia, angioedema, histamine release, and hypotension. Now you might say, well, coagulation gets activated a lot of times in various patients, but no. COVID-19 is special. It is the tangled web on steroids, 100-fold times greater activation of all of these systems that the body is using as a defense. And Oscar Ratnoff has reminded us of something very important, talking about his tangled hemostatic web. And I want to read it to you. The thesis of my talk is not new. We think about clotting, fibrinolysis, immune reactions, and inflammation as if they were separate and separable processes. In truth, these distinctions are man-made. In real life, it is the body as a whole that responds to the injury. The processes through which it defends itself are interlocked like pieces of a jigsaw puzzle. We may be intrigued by the individual pieces, but the picture emerges only when they are put together. And then that produces the final result. And this is a plea now to all of us, the clotters, the inflammatory doctors, and the immunologists, to get even closer together and to pool their results in order to attack this problem. And needless to say, anticoagulation alone is not the answer. Now, when this pandemic was happening all over the world, people started using all kinds of doses of anticoagulation, and sometimes there were incredible elevations in D-dimer, so they'd be increasing the dose of anticoagulation with very poor results in most cases. Some good results, but very poor results, a lot of bleeding, and it was obvious it wasn't the answer. So as a result of that, there were some very important trials organized. This one was organized as an NIH multi-platform. It's published in 2 articles in the New England Journal. And what it showed was that they were talking about prophylactic versus therapeutic anticoagulation. And they concluded in the severely ill patients, it did no good to escalate the dose of anticoagulants. It only increased the bleeding. However, in moderate risk patients, therapeutic anticoagulation was superior to prophylactic dose anticoagulation in reducing the need for organ support and mortality in moderately ill hospitalized COVID-19 patients. But a detailed individual risk assessment wasn't done. Now, following close on the heels of that and presented at the American College of Cardiology was the ACTION trial. Again, brilliant investigators. This was from Brazil, and they did a beautiful job putting together a very, very well done protocol, showing just the opposite of the NIH multi-platform. In-hospital therapeutic anticoagulation, followed by 30 days of rivaroxaban, did not improve clinical outcomes and increase bleeding compared to in-hospital prophylactic anticoagulation. Exactly the reverse. The first study said therapeutic was good for non-seriously ill patients. This study shows prophylactic is just as good and therapeutic has no advantages in these patients. Well, what's going on here? I am nowhere the caliber of all of these brilliant people that put together these studies. But I have one simple comment, and my comment is lack of thorough individual risk assessment one explanation for disagreement regarding the benefits of anticoagulation in COVID-19 patients? We know putting everybody in the same shoe is not a good idea. Recently, a trial was done at our institution using the Caprini Score with the very, very well-established improved score from Alex Baropoulos. And Alex did this with Alfonso Tafur from my institution. And they showed that a linear increase in scores of either document would be able to be associated with the incidence of DVT and death. So as the scores went up, the incidence of DVT went up, the incidence of death went up. And here is the improved score, and here are the results for DVT and rather mortality. And you can see that it's classic. This is very, very obvious. Patients with a low score, their mortality is very low. You wouldn't give them a therapeutic anticoagulation. It would only increase their bleeding. However, if they have a very high score, look at how it jumps into the high 60s. Those patients may deserve more. And now here is the Caprini score, because we have various categories. I've just chosen to show them this way. Those patients that are at low risk, almost no incidence of DVT. When it gets up to a score of 9 and above, almost 30% incidence of DVT. But what's even more compelling is the death rate. Patients with a low risk score have a low death rate, but if it goes up to 80% if the score is over 9. Well, surprise, surprise. Why do we have to relearn the lesson that risk assessment needs to be done in patients, medical and surgical? It was clearly shown in some of the great work that was done by Alex Spiropoulos, showed that before the pandemic, the use of rivaroxaban protocol using the D-dimer improved score resulted in a 56% symptomatic decrease in VTE events without increase in bleeding. Why haven't we learned that for COVID? Aha. Along came the Michelle trial, authored by Eduardo Ramacati and a group of brilliant investigators from around the world. And they showed, and of course, Alex from his institution and Alfonso from our institution were all a part of this. And what did they show? First of all, the trial was a composite of symptomatic VTE events, VTE-related death, asymptomatic VTE, and symptomatic arterial thrombotic events, myocardial infarction, non-hemorrhagic stroke, male, and cardiovascular death at day 35. You can clearly see a 67% relative risk reduction in the incidence of this composite primary outcome. And these results are astonishing. They clearly illustrate the most important lesson I know I've learned from COVID-19, risk assessment. We're again reminded about the importance of history. And the results of this trial, believe me, are going to be a game changer and lead to improvement and decreasing in deaths across the board from COVID-19. So in conclusion, I'd like to leave you with a saying that came from my dear friend who recently died in Maine. He was an academic dentist with unbelievable common sense. And when listening about my risk score, he said, Joe, it's very simple. When you meet somebody, you have to do a thorough history and physical like you're talking about. So they're no longer strangers. They're your friend. And of course, once you know all of that, you'd protect them. You'd never kill a friend. You'd never treat a stranger. So, ladies and gentlemen, are we treating most COVID-19 patients like strangers without individual risk assessment? Critical exercise, especially during COVID-19. I'd like to thank you all for your attention. I wish you a great Congress, and everybody stay safe and have a wonderful day.